Three, two, one. We are live now, sir.
Okay, warm welcome, colleagues. This is the third session of research seminar of Johari Medical and Research Foundation Quest. I am Dr. Dhiren Ganjwala, a pediatric orthopedic surgeon from Ahmedabad. Along with my senior colleague, Professor Ashok Johari, we both will host this session. So first of all, let me give you a brief background about this webinar and the Quest. We all know that research is not a top priority in India due to various reasons. And to change this mindset and to build a culture of inquiry amongst young pediatric orthopedic surgeons, we launched the Johari Medical Research Foundation Quest. These webinars are basically an extension of this Quest, and they aim to encourage critical thinking, basic research skill, and long-term academic interest among young clinicians. The theme for today's session is Glimpse of Research on Lip Reconstruction. And the esteemed speaker is Dr. Harpreet Chhina from University of British Columbia, Canada. At the outset, I sincerely thank OrthoTV for this unconditional support for this activity. And without OrthoTV, it would have been difficult for us to reach such a large audience. Before I hand over to Professor Ashok Johari, let me tell you that if you have a question, please WhatsApp me on number 97129 25600. I repeat, 97129 25600. Now I request Dr. Ashok Johari to speak about today's topic and also introduce our expert speaker. Thank you, and over to you, Professor Johari.
Thank you, Dhiren. It's my pleasure to introduce Harpreet. Many of you may have met her before at the POSICON meetings. I think she has come, at least definitely I recall once, but I recall twice actually, having met you, at the POSICON meeting. Now, Harpreet works at the University of British Columbia and the BC Children's Hospital. She's a hardcore researcher. She's researching into limb reconstruction. Her topic today is Glimpses of a Limb Reconstruction Research Program. It's diverse approaches to clinical research questions. To give a background about Harpreet's work, she actually started off as a master of anatomy from Punjab University, then over to Canada, where she did her master's as well as her doctorate degrees in experimental medicine at the University of British Columbia. Now, she's working there largely on limb reconstruction research. She runs many programs there. Her work is concerned with patient outcomes, quality of life, and all sorts of surveys, for knowing what we are doing and how that is actually working out from the patient's point of view. She designed a sort of, let's say, a program to assess limb differences. She runs that ILDN, the International Network for Limb Differences, but she described this limb QOL for kids, or LimbQ for kids, which is a sort of assessment tool for what is happening with limb reconstruction in kids. And I think she's working very hard to translate that into different languages, do multicentric collaboration, running a big team, which does multicentric collaboration and tries to sort of get this going, sort of highlighting the importance of feedback and knowing what is happening after we have done surgery, for patients. So Harpreet is also involved with the Canadian Pediatric Orthopaedic Society and with the ISO QOL, that is the International Society on Quality of Life, as a chair for the children's side, for the committee which works on sort of children's quality of life. So Harpreet is going to tell us a lot. I will tell you something more about Harpreet later on in the program, towards the end of the program. But now over to Harpreet. Go ahead, Harpreet.
Okay, sounds good. Are you able to see my screen, Dr. Johari?
Yes.
Not yet.
Not yet. Okay. Let me just.
Yes, now it has started.
You can, okay. And you can see my slides
Yeah,
moving?
perfect. Yeah.
Okay, perfect. Okay. Thank you so much for the kind introductions and inviting me to this webinar. I have seen there are so many expert clinicians who have been on this platform, so I really feel honored to be invited to talk here today. My presentation today will be a little different from the other talks you may have seen on this platform. So rather than focusing on a single clinical topic, I want to provide a broader overview of a research program. I will also highlight a few key projects and, more importantly, the research designs behind those projects, what worked well for us, why we chose those approaches, and how some of those models could be adapted or replicated in an Indian context as well. So my goal today is not to provide answers to clinical questions, because first, I'm not a clinician. But I want to spark curiosity, encourage research, engage in some discussion today, and hopefully inspire new ideas and new collaborations in research. Okay, so this is just my educational background. So I'm going to very briefly touch, as Dr. Johari already talked about it. So I started my education as an undergraduate degree in biomedical science in Medical College in Amritsar, followed by a master's degree in human anatomy from Chandigarh. Then I moved to Canada and did another master's degree in experimental medicine. And this is where I actually got exposure to research. I learned how to do research. I learned various methodologies for research, qualitative, quantitative, and how do we actually apply that. And then I continued on to do a PhD in experimental medicine, which is where I did a lot of work on development of outcome measures in pediatrics, and I learned the methodology behind it and how do we develop and validate patient-reported outcome measures. So in my current role as a research associate in the Department of Orthopaedics, my role spans everything from shaping research ideas, writing project proposals, to grant writing, manuscript development, and helping with the overall strategic vision for a research program. A key part of my work is knowledge translation, which is making sure that our research doesn't just get published in medical journals and just stays there, but it is understood, used, and has an impact for actual practice. I also provide methodology, design, and project consultation to trainees at various levels, starting from undergraduate students, master's students to PhD students, clinical fellows, and postdoctoral researchers, helping them shape clear research questions, choose appropriate study designs that are both rigorous and also practical to conduct. In terms of pure research, I do a lot of mixed methods research, which includes both qualitative and quantitative research designs. I also develop and design registries and databases to collect data at large scale. I also work on the development, validation, and implementation of patient-reported outcome measures into clinical practice. And lastly, I'm also heavily involved in training and mentorship to a wide range of students and medical trainees. Okay. So this is my team who I work with. So this consists of two orthopedic surgeons, Dr. Tony Cooper, who is also our head of the Department of Orthopaedics at Children's, Dr. Carrie Colliers, and then we have a postdoctoral fellow, Dr. Takdir Ali, who is our AI expert. And then we have research coordinators and assistants who help us run the program by collecting data and keeping a lot of coordination of our research program. In terms of the core program, we primarily focus on children with limb differences, which includes a wide range of limb deformities, congenital and acquired, a lot of angular deformities as well. So it is a very wide range of patient population that we work with in our program. In this slide, I have a very quick overview of how we look at our program. The vision of our program is that no child suffers from a limb difference. And our mission is to improve the health-related quality of life of children with limb differences. Broadly looking, I see a program divided into four components. The first one is around databases and registries. So we have our in-house limb differences database, which is where we collect a lot of clinical data on any patient that comes through our limb reconstruction clinic. Then we have an international limb differences registry, where we work with many international partners to collect data on many different kinds of limb differences. And lastly, the newest addition is the pediatric foot registry, which we have just started developing at our center, and then we will slowly expand in our country and internationally. And I will touch on these projects in a little bit more detail in subsequent slides. Next component of our program is patient-reported outcome measures, which is my favorite topic and also my area of expertise. So I lead the development and validation of patient-reported outcome measures for musculoskeletal conditions. And then once they're developed and validated, I also work with teams across the world to translate and culturally adapt those outcome measures so that those outcome measures are available in non-English speaking parts of the world as well. And lastly, I work towards incorporating these outcome measures into clinical practice, because what's the use of developing those outcome measures if they don't reach clinicians and they are not able to embed those in their clinical practice. So that's also an area which I find really exciting. And I'll also talk a bit more detail about that. Next component of our program is patient engagement and knowledge translation. So we work very closely with our patients, which are generally young kids, adolescents, and their parents, to listen their stories. And then those stories are then used for creating knowledge translation pieces to share with other patients and families. It goes on our websites. So that is where we just don't do research on patients, we do research along with the patients. And the newest component in our program from last few years is artificial intelligence and machine learning. So I'm not the expert here, but I work very closely with the AI expert in our team. We have few ongoing projects, which I will very briefly touch on towards the end as well. So first of all, talking about our in-house limb differences registry. So it is a very simple design that we have implemented here. Any patient who comes through our limb differences clinic is invited to participate in this registry. And most of the times, I would say 90% of our patients consent to participate. So what we do here is we collect the data that is routinely collected for their clinical care into a data management tool. So there are no extra visits. So I have listed some of the examples of data variables like X-ray, imaging, range of motion, gait evaluation, surgery, complications. So those data sets are collected as part of clinical care anyways. So why not use it for research? So we launched our in-house database in 2015, and since then we have over 500 patients in this database. So why this design works for us? So as I was mentioning that it just leverages routinely collected data. So there is no requirement for additional visits. It is easy to implement and is supported by secure and accessible data capture program called REDCap at our center. So I think this design could work in low resource settings as well, as long as you have even if you have a very simple data collection or management system at your center. This is a really good way to collect data that you have anyways, and then go back and look at this data, do retrospective reviews, and answer important questions. So I looked a little bit more into REDCap in India because we use it for a lot of, primarily for all of our research programs, that it is also available for teams to use in India, and it is free of charge. And in fact, I think AIMS and Indian Childhood Cancer Initiative in Chennai already uses REDCap. So it is a really good data management tool if anyone is looking into using it. Easy to set up, and there is no fee for the users. So using this very simple design, we have been able to answer several research questions and clinical questions in past several years. Some of the examples I have put it on the screen, and these are like just few of those examples. We were able to look at pin site infections, which is a very common complication of using external fixator devices. So we collect the data on patients anyways. We were able to look at the pin or wire materials, their cleaning protocols, or what is it that's causing these complications? Can we tease those things out? So some very simple, very easy data collection modalities, and then you can answer those clinical questions, or at least try to look into those ones. We did few studies on looking at the efficacy of sleeper plates for guided growth procedures. Then one of our other clinical fellows looked at the plate material, right? Is the plate material leading to complications or tethering in some cases? One of our other fellows is looking at percutaneous epiphysiodesis using transphysial screw versus curettage for leg length differences. Another fellow is looking at just purely broadly congenital versus acquired lower limb differences, how these patients differ in their treatment trajectories, type of surgeries, their complications, and how are the outcomes different. So since we have this data, we can ask many questions that the clinicians often wonder, and those could help them in clinical decision-making and then counseling patients and parents afterwards. Just few examples. But there's also a bonus for if you involve trainees and fellows, that because then they can publish papers based on this data. So there is an incentive for them at the other end as well. This is just screenshots of few of our papers that came out recently around sleeper plate, comparing Taylor spatial frames or the Orthex frame. So it's a really good design to collect data, and then you can publish an incentive for the trainees to do this kind of work as well. And we did like the pin site infection study locally at our center, and then we were like, oh, it's a simple design, observational. Why don't we expand it to other centers? We invited other centers. It's purely observational. If you can collect this very basic data, maybe we can all pull the data together and look at a larger set of frames and see if we can look at what are the factors causing pin site infections, and we can build end prediction models. So we did this multi-center pin site infection study, and we're just finishing up data analysis and manuscript. We are now able to look at 200 frames across 8 different centers, and hopefully this will give us some insights into the factors that lead to pin site infections in this patient population. So a simple design at one center, if we just expanded it to other centers, could be a really powerful design. So now moving on to our International Limb Differences Registry and network. So we established this network about 3 years ago. It is a global network of orthopedic surgeons, researchers, and allied healthcare professionals with the common goal to improve the health-related quality of life of patients with limb differences. So we are just bringing people together who have this shared goal. As a first project under this network, we launched the International Limb Differences Registry 3 years ago. The establishment of this registry was funded by a POSNA registry grant. So this is a prospective international registry encompassing a wide range of diagnoses causing limb differences. As you see in this pinwheel, there are 10 different conditions that we are including in this registry. So it is a very broad inclusion criteria. Patients between the ages of 0 to 18 years at the initial presentation, if they have a diagnosis of one of these conditions, can participate. And now we are slowly building one registry at a time so that we can collect data that is relevant to that condition under this framework. We have launched our osteogenesis imperfecta registry last year, and just within like less than a year, we had over 100 patients. Musculoskeletal infections registry was launched a few months ago, and we're just starting to collect data. We have a MARQB registry, which is up and running. And then the next one is congenital pseudoarthrosis of tibia, which will be launched in coming months. And then we have several more, which we will develop over the course of next 5 years. So what we do in this design is we provide all the methodological expertise, resources, database management from our center, but we work together with clinicians and teams from other parts of the world. For example, for developing the musculoskeletal infections registry, we have a surgeon from India, we have a surgeon from UK, we had people from Canada and US, and together we decided what are the clinical variables that are important to collect for this condition. So that advisory committee is then responsible for that core structure, and then we build that registry here. So that is the model that we use for all of the registries, so that just one person here in Canada is not deciding what is important to collect. We involve representatives from all parts of the world with a specific focus on representatives from low and middle income countries, so that the registries are applicable to those parts of the world as well. So this map just shows some of the centers that are actively involved at this time. But as you can imagine, it takes several months to a year to get the ethics approval and then the legal contracts to transfer the data. So sites are slowly coming up, and we have 15 sites that are actively up and running at this time. And there are several more that are in the process of getting the approvals to transfer the data. So this is just like an ongoing process. We have one center from India that is already up and running from Pune, and PGI-MER Chandigarh is also in the process of obtaining approvals, and I hope we'll have many more from India who we can work together on this important initiative. Okay, so why this registry design is useful? It could be applied in many conditions, but I think it is particularly helpful in rare conditions where there are not enough cases at one center. Pooling the data across centers allows for sufficient sample size, and then you can answer your research questions with much more confidence. When there is variability in practice, especially clinical practices, surgical techniques, or healthcare delivery could differ between countries, right? So it helps you identify which approaches can lead to better outcomes, and then can inform best practice guidelines. We can also have access to large numbers of data because we are pooling data from different centers, diverse populations, which are diverse by ethnicity, healthcare systems, and then with that data, we can detect the long-term outcomes in that patient population, some rare complications, which you may not be able to see when you are just looking at a handful of patients at your center. Then there are questions around health policy and benchmarking, which could also be answered through this registry-based design when you have access to a large set of data from different parts of the world. And you can provide evidence to inform global health policies or resource allocations. And lastly, patient-reported outcome measures are really nicely implemented through a registry design because you can use standardization across different centers and then look at outcomes from a standardized outcome measure perspective, and then see how those outcomes may change when patients are in different settings. So this design could be implemented in a stepwise manner. If you're starting small, you can set up a registry at your own center first, expand to your province, then to your country, and then if you think, then you can expand it to other parts of the world. So you don't always have to start big, but this design could be really meaningful at a small scale as well. Okay, so next, my favorite topic, patient-reported outcome measures. So patient-reported outcomes are reports that come directly from patients without any interpretation by clinicians about how they feel, how they function in relation to their health, their medical condition, or their treatment. They capture outcomes that only patients can truly report, such as pain, physical function, emotional well-being, their social well-being, and their overall quality of life. PROMS really allows you to measure what is it that matters most to your patients. They are also a really good complement to clinical and radiographic data and outcomes. So then you have a really nice complete picture of your patient. You're not just looking at clinical and imaging data in isolation. You are then able to look at it in a more comprehensive way and hopefully can provide a more holistic approach to your treatment. PROMs also help you look at the comparative effectiveness research when you want to compare treatment options for a specific condition. If you know one treatment option gives you better patient-reported outcomes, then you would hopefully prioritize that as opposed to others. So if you don't have the outcome measure that you're using, it is really hard to just look at those outcomes just purely from a clinician's perspective. And lastly, PROMs can be really helpful in quality improvement initiatives in your hospitals or in your teams. Maybe your hospital wants to know how is your program doing, so you can show that when you collect patient-reported outcomes that I did a surgery and this patient has now improved, their outcome measure scores were here and now they're going up, which means the treatment you're doing, the management you're providing is improving. Maybe your funder wants to know, okay, what are you doing with the money? Oh, this is what we are doing, and this is how we're improving patient outcomes. So it really gives you that tangible outcome to look at in terms of if you're looking at purely quality improvement as well. So why use PROMs in low middle income countries? And I often get asked this question, that how do you talk about PROMs or outcome measures in settings where people still struggle to get basic healthcare? But I think this is where it is even more important to look at patient-reported outcomes, because they help you capture real-life functional impact, daily functioning for your patients, their work, their school, their mobility, their pain, and emotional well-being. So you actually really want to know how your treatments are impacting the functional outcomes in your patients. Healthcare resources are often limited. So PROMs can help you prioritize the interventions that matter most to the patients, so that you're not wasting your healthcare resources to outcomes that you know are not going to give the outcomes for your patients. PROMs can also allow you to measure outcomes just relative to the cost, which is really, really crucial in low resource settings, right? So you want to maximize the benefit to your patients. And lastly, PROMs ensure that these limited healthcare resources translate into meaningful improvements for your patients. So next, I want to talk about LimbQ Kits, which is the patient-reported outcome measure that I developed as part of my PhD. And it is a new outcome measure for children with lower limb differences. And we developed it following international guidelines for PROM development as mandated by WHO, FDA, and International Society of Pharmacoeconomics and Outcomes Research. So we followed all those guidelines closely. We started off with really understanding from these children that what is it that matters most to them. So I did interviews with children in Canada. I also did interviews with children in India, in US, and I trained a researcher to do these interviews in Ethiopia. And then that really allowed us to understand how are their lower limb differences impacting their life, regardless of where that patient is, whether they are in India or they're in Ethiopia, they're in Canada or US. Based on that framework, then I wrote items that formed the basis of this outcome measure. And then we did 2 international validation studies where we collected data from over 800 patients from 7 countries, 16 sites, to validate this outcome measure. And there were centers from India who were involved in those validation stages as well. And now this outcome measure is ready to be used for almost a year. It has 9 independently functioning scale, which means it can measure 9 different domains in those patients, such as their perceptions about their leg appearance, physical function, symptoms of leg, knee, hip, foot, and ankle, their distress that they have because of their leg, and the overall psychological and social well-being. So if you only want to assess physical function in your patient, you give them the physical function module to complete if you want to look at your patients, all of the domains at one point, you give them all of the questions to complete and get a score for each one of them. So it is a modular approach, which really allows you to pick and choose what you want to assess in your patients, whether it is for clinical care or for research. So while we were developing this outcome measure, I also worked with several other teams around the world to translate it into many different languages. It is currently available in about 10 different languages, including a version in Hindi, which could be used in India as well. And we have about 5 other translations that are in progress right now. So that is really ensuring that the outcome measure that is validated is appropriately translated, following the rigorous guidelines, and then also culturally adapted for each and every country where it is then going to be used. So the implementation of prompts is something I am also involved in past few years because I've spent a decade developing this outcome measure, and if it is not getting used in clinical practice, then there's no use of developing those outcome measures. So so this picture on the left-hand side shows our clinical team, our surgeon, and rest of the team. So they meet before the clinic, they discuss each and every patient, and when they're discussing their clinical scenarios, our research assistants presents the outcome measure score. So you see the graph at the back. This is them looking at how their scores changes over time. So they are really able to look at the patient, their clinical history, their surgical details, and patient-reported outcome measures at the same time. And when they go see the patient, they can have much more meaningful conversations about how they are feeling distressed about their leg, or they are not happy with the appearance of their leg. So it really allows them to provide more like a holistic care to patients, not just treating or just fixing their bones. In the other picture, we have a research assistant showing these graphs to the patient who completed these outcome measures and the parent. So every visit, they get to see how their scores changes after a certain period of time. That allows them to be more engaged in their care. There are improvements, or the scores are dropping, that really makes them aware of what's happening. And sometimes parents are not aware what's going on with their child. They are psychologically impacted because of their conditions or their treatment. So it really creates that awareness about what's happening and allows patients to be more involved in their care. In this slide, I have a screenshot of our visualization platform. So this is how the scores look like. So this particular patient had completed scores for left side. So they completed prompts at 3 years and then again at 3.5 years. And we can see how their scores have changed. So some scores have stayed the same, which is good. Some scores have dropped and some scores have improved. So this is how the clinicians see the scores, the patients and the families see the scores, and they're really nicely able to pick up where there are changes. We have also created automated emails that when a score changes by 10 points, we get an email and we can actually see what is happening with this patient, even if they are not scheduled to come back for their routine clinical care. So again, very simple graphs, very basic models, which I think in Indian technology, people can create very easily, but a really powerful tool to look at the outcomes in a visual manner. So this is another study along the outcomes area. We are also developing an outcome measure that we can give to children and see what is it that they like or dislike about their prosthesis. So this is specifically for children with limb deficiencies and amputations. So the hope here is if we have an outcome measure that allows us to measure their satisfaction with their prosthesis, that information can then help prosthetic design makers to improve the design, which will then hopefully improve the satisfaction and then the use of prosthesis, which would then increase their function and overall quality of life. So this would be another addition to our outcomes program, a tool to measure satisfaction with prosthesis. So next is our randomized control trial, a very different design from the ones I have talked, but again, a very simple design. The idea came around COVID-19 pandemic when we were saying, how do we minimize patient visits to the hospital? How do we minimize contact? So we looked at the management of type 1 supracondylar humeral fractures. A multi-center randomized control trial comparing soft cast versus hard cast. So we were really trying to see if we put these kids in a soft cast, which is removable at home, they don't need to come to the hospital. So this could be a useful design in low resource settings. People don't have to travel, they don't have to come to the hospital, and we also removed the 3-week X-rays in the soft cast group. So maybe it is not needed. So this design will really help us see the outcomes in these two groups, and hopefully allow people to understand that we could reduce patient visits, X-rays, and would help with healthcare resources as well. So we did first visit, 3-week post-fracture, the patients removed the casts at home. The other group, the standard hard cast, came back to the hospital. They had their X-rays, and then at 6 months post-fracture, both the groups stayed at home, and they took pictures of their elbows in specific positions, we told them, and those pictures were used for measuring carrying angles and other range of motions. We just finished this trial, and now we're going to get started with the analysis, but on the preliminary analysis of the interim data, there weren't any big differences in outcomes for this one. So again, a simple design could sometimes answer your valuable clinical questions. So the last program component is patient engagement and knowledge translation. So these are just some basic definitions. So patient engagement means actively involving patients and families as partners in healthcare and research, not just as the recipients of care, but also as active contributors to decision-making, design, and improvement of the services that actually impact them directly. So for knowledge translation, it means making sure that research does not just stay in medical journals, but it actually reaches clinicians, patients, policymakers, and communities in a way they can use it. So in our program, patient engagement and knowledge translation is a really important component because it can lead to meaningful improvements in clinical care. It can help in delivering care that is evidence-based, patient-centered, and contextually relevant. So what we do is we work closely with patients and families. We sit down with them. We understand their stories, their journeys as they go through these diagnoses and complex procedures. And then those stories are then turned into written summaries, videos, infographics, and then we post those either on our social media or they are posted on our clinic TVs or on the website. Patients share really touching stories about their treatment and also experiences of their treatment. They share tips and tricks such as what did work for our child for pin site cleaning, the clothing adaptations kind of thing. So those are some really valuable pieces of information that patients are happy to share with us, and then we translate into knowledge translation tools. So just a couple examples. One of the things which our patients really wanted to know was understanding their frame, because they are going home, they are then turning the struts for their lengthening. So we made this infographic explaining what a frame is, what are the struts, where are pins and wires, what is it called, what is it doing, which could at a very low reading level, which 8-year or 9-year-old child can also understand. So that's just one example. And on the right-hand side, we worked with a patient who was a bilateral amputee. They shared his story right from birth till like now when he's in Paralympics. And those are really meaningful stories for patients to connect patients with similar experiences, provide emotional support. They can see that if others have gone through these complex procedures, similar experiences, they can do it too. So something I think easy to do in a low resource setting as well. You could just put those things on a piece of paper and leave it in your clinics or waiting rooms, but could be a really powerful tool. This is just a picture. I didn't make it. When I was doing some research, I found that patient engagement in Indian context, so I put it there. Again, I did not make this picture, but it really highlights that how patient engagement is just listening to patients' experiences, understanding if they have any questions about their care and can we turn those into research questions, improving their care, improving their outcomes, but also respecting their culture and values when we work closely with them. So it was a really nice image I found. So why is knowledge translation critical in India? Because it bridges research and practice in a complex healthcare system. So the healthcare system in India is fragmented, and in many other nations as well, public versus private, urban versus rural. So knowledge translation ensures that research evidence reaches the clinicians, the administrators, and the patients who needs it, rather than remaining in journals. It reduces variability in care because clinical practices vary widely across hospitals and regions. So knowledge translation can promote standardization of care and adoption of evidence-based guidelines to improve outcomes across diverse settings. It can also support resource-efficient care. So healthcare resources are often constrained, especially in public hospitals and rural areas. So knowledge translation can help clinicians identify interventions that are effective, feasible, and cost-efficient, and can maximize patient benefit. It can also accelerate the implementation of evidence-based innovation. Innovation often fails to reach remote areas, right? But the knowledge translation strategies can help reach these innovations to global audience, and those can then turn into actionable items at the local centers. So the last component of our program is AI program. And as I said, this is not my area of expertise, but I work very closely with our AI fellow. So my role there is when we're writing project proposals, how do we ensure that it is a sound research proposal? How do we get through research ethics approvals? How do we go through our hospital privacy reviews? Because there is tons of data from the patients going into training those models. How do we access that data? And then once we get the data, how do we still ensure that there's transparency in those projects? How do we keep the data secure? Where is that data saved? And once these projects are done, how are they implemented in actual practice? So just a couple of the projects I have shown here. One is around identifying fractures through machine learning. So we're just about to finish this. So this model can then identify if there's an elbow fracture or not, the type of fracture, the location, and eventually we will turn this model into helping with decision making as well. The next one is around limb alignment calculation, which is really crucial in limb deformity planning. And so if a clinician's doing it, it takes precious time away from them when they can spend their time doing other things with or just doing clinical consult. So some of the angles we thought that are regularly measured, why can't we automate the process? So we are now training the model using our lower limb radiographs, and our first iteration was very promising. It just takes seconds to measure those angles, and it puts those landmarks on the x-rays. And if you're using this program and the clinician thinks, oh, these landmarks are not correct, they are also able to go in and edit those landmarks if they're not correct, and then regenerate those angles, and then the training model keeps improving over time. And lastly, a bigger project which is in progress is called Ortho Assistant, which is a dialogue-driven documentation and decision-making. So it is looking at capturing patient and doctors' conversation, their dialogue, extracting data from it, and then de-identifying that data, and then using that information extracted from that dialogue and seeing, has the clinician missed anything important that they need to ask, providing prompts to the clinician. And then that extracted data along with the clinical data and the imaging data, creating a decision-making prediction model. So that is also in progress at this time. So this is the end of my presentation. Thank you to everyone for listening. And I would also like to thank my team at the University of British Columbia and Children's Hospital, who I get to work with every day, get support from. And our program is also funded by Children's Hospital Foundation. On the screen, I have some QR codes that show our Walkthall website, which is a patient-facing website with all the patient resources and knowledge translation materials. Our more clinician-focused website, ILDN website, and our LinkedIn page, which also has some research resources and information. And I will stop sharing my screen.
Yeah, thank you, Harpreet, for excellent overview of your research activity. It, I think, comprises the full spectrum. So let me ask a simple question, and that's question which is pertain to almost all pediatric orthopedic surgeon, and that's about clubfoot. So in clubfoot, when we look at the result, in India, it's very important that a person is able to squat. No doubt now we are changing the tradition, and very few people they use the Indian style commode, but dorsiflexion is required. Now, if we are using the Western patient outcome measures, in that case, if it is not there, and for India we want to modify it, what is the process?
That's a very good question. So that is where the cultural adaptation comes in. So say initially we might have a question that how do you sit on the floor or something, right? And in fact, we had this question about squatting in LimbQ kids as well, and then it got removed. But in an Indian context and many other countries where people still have to sit down on the floor, you can adapt that question, right? So that is where cultural adaptation is. You can adapt questions based on that, or you can give examples. Like, for example, you say, are you able to sit on the floor? And in brackets, you could give those specific examples, such as squatting or using the toilet. So you could adapt those questions accordingly so that they are relevant to local context as well as to the bigger context. So the question is initially designed to capture the concept or the actual thing that you as a clinician want to assess, which is sitting on the floor, right? The examples could be different, and then you can adapt accordingly. I hope that answers.
Oh, but like say, suppose it's a 100-mark system, and then when you add this point, there will be change in the marking system. So how do you do that?
Yes. So then you have to do your quantitative analysis again at that point if you're adding a question. So it is not methodologically correct to just add an item at any point. Then you have to do the adaptation again. But the idea of doing global work is that from the onset, you capture all the concepts from different perspectives from the beginning. And then as you go, you can adapt and modify those items from the beginning, that you don't have to do those afterwards. And also a thing to remember is you don't want to design a questionnaire that has 100 questions. So the beginning, so when I started LimbQ Kids, anything that I heard from children in the interviews, any concept was turned into a question. So there were 159 questions. So there is no way we can give that outcome measure to a child. So then you do quantitative analysis to select best items based on their performance and based on the testing data you have. And some of the items get eliminated. And so that's how you go from bigger set to the lower set. But in the beginning, you always start with everything. And I did start with the question around squatting, sitting cross-legged on the floor. So those kind of things did come from India and in Ethiopia as well.
Okay, then there is a question from the audience. The name is not written, but the question is about the rate cap. The question says
Sorry,
that in
can
the
you say
rate
it again?
caps, rate cap,
Okay.
Red cap.
rate cap.
Red cap, yes. Okay. Yeah.
So the
Okay.
problem is now the Indian government is saying that you should not have your data stored outside India server, and RedCap server is out of India. So doing or participating in such activities is basically transferring the Indian patient's data on the other outside India website. So I'm sure that you must have come across this question and this challenge. So what is your uh, like perspective on that?
Yeah, that's a very good question. And in fact, I don't have the answer to that from an Indian perspective, because we have many collaborators in India who want to participate, who want to collaborate, and they will have to go through this government approval. So I think they will have to navigate and see what their government allows. But another option could be to just store your data locally, because when we design RedCap, that's a design, right? We can give that design to you. You store, keep that data locally at your center so that it's stored there. But if you want to collaborate and we want to look at the data together, the data will still need to be transferred to us at some point. But that could be done through different ways. But RedCap itself can be hosted just in India, and you can host your data there. But that doesn't answer the data transfer question, unfortunately. But I hope there is a way around it with the data transfer agreements that we can work through those. Yeah.
Yeah, over to you, Ashok, for some question, and then again
Yeah.
we will have more.
Harpreet, some basic questions, now you talked about multicentric registries, registries where you get data from many centers. So how do you standardize that data? How do you know that everyone is giving you data in the similar format? And
So
do you have a common education ground for all the people who participate in your registry?
yeah, so that's a very good question. So that's where when we involve people from different parts of the world from the starting, while we are selecting the variables, so that's where that standardization starts, right? What we think is important for data perspective for musculoskeletal infections might be very different for a patient in India, right? But when we had experts from India who treat those patients on a regular basis, we were able to identify common variables that are relevant across different parts of the world. There were some things that we knew we are not able to collect in India or Ethiopia or in other parts of the world. So that's the benefit on working with experts from the beginning. Then we define the core things that everybody can collect at the same level, standardize it. Those are the core variables that everyone does. And then we have a set of optional variables, which if you have resources, you can collect it, you do it. But these are the core variables that will help us all understand this condition and answer questions, no matter from where that question comes from. So that's the first layer of standardization. Second, we provide training to all the centers. In terms of basic RedCap training, we make very detailed data entry manuals, written manuals for each condition and registry. So people who have zero experience can also follow that manual step by step and collect and enter the data. Very often, data collection people are not clinicians, right? And for example, at our center, we have undergraduate students who are still in university, have no idea if they're going to go to med school or not. But if you have those standardized manuals, they are able to look through and then collect the data from patient charts, or can ask the clinician that this is the data we want. So that is the second layer of training, data entry manual and training. So anytime a site joins the registry, our team meets with them, provide them the training, help them set up. And then this doesn't stop. We do have multiple checks over the time period. We do monthly data quality checks. So data is looked at every month from every center, and then we write back to the centers, help them correct those errors if there are any or any missing data. So it's like an ongoing process. And a lot of training and support is involved. And hopefully this will help standardize data and also maintain the quality of the data as much as we can.
So, Harpreet, is there any data which is then put in a retrospective fashion, or is it always all prospective?
So we have, so both. So for example, for the ILDR registry, though it is a prospective registry, but we also have a retrospective section. So say you are enrolling a patient today for their prospective data, but at the enrollment, you will be asked questions. Has this patient had any infection in the past? Yes or no? And then there's a whole stream of questions you can answer about that patient in their past data. For example, for OI, at the beginning, it will ask you, has this patient had any fractures in the past? Have they had any imaging done, any surgeries done in the past? And some of the patients with OI have had like 10 fractures in the past, 10 surgeries. So there is a section to collect that retrospective data. And then, so we have a complete information on that patient, what has happened to them in the past, and then prospectively we collect data. The retrospective section is also tailored because we know not every center will have resources to input 10 years worth of retrospective data. That's why if a center has resources, they can enter 10 years worth of retrospective data. It is all designed to capture it. But if a center has no resources, there is a very basic form they complete, which will just ask you, how many fractures did they have in the past? How many surgeries did they have in the past? What were the complications? So just very basic. And then we know in a summary that what happened to this patient in the past. So there is an option to connect.
Yeah, you mentioned about the knowledge transmission or the knowledge transfer. Now, suppose we have done a good study. We have found out something interesting. Now, the most important thing is like people should start using that research, or we need to use that research in the practice. So do you have any strategy, any plan to enroll more physicians to use that research? How do you do that?
Yeah. So the first thing is there will be multiple levels of knowledge translation, right? One is during you're doing that project, and then one is end of the project knowledge translation. So while you are doing that research, you have to start creating awareness about it as you're going, which is like the integrated knowledge translation approach. So you know who will be the best benefiters of that knowledge, which maybe there's a specific group. So you make them aware, you bring them to the same level while you're doing the study. So that's first level. Then they will know, okay, this study will have something that I can then use in my practice. So that's the integrated knowledge approach. The second is at the end, like your medical journals is just a very traditional knowledge translation approach, but presentations, abstracts at conferences. And then social media is like great these days. You can make those infographics, you can make those videos and translate that results into easily digestible knowledge based on your audience. So we are in a program, we're just looking at what are the best ways to transfer knowledge to a clinician, to a parent, to a child. So there has been lots of research, and we are going to look into that in future to find those optimal methodologies for different audience. But it will then have to be tailored. Like we think maybe Instagram stories are best for adolescents, for children, right? But no, like right now people are doing TikTok videos to do that. There is published stuff on that one as well. So I think there are multiple layers of knowledge translation that I think you have to keep in mind right from the beginning. You can't just wait till the end.
Yeah. So Dhiren, I think we have only a few minutes left. Would you want to say something?
Yeah, just no, the one question, very quick question, because Harpreet is a very unique of our three experts. You have seen the Indian scenario where you will agree that the research is not a priority. And now you are in a completely different setup. So what do you think the research is not priority? Or in the other way, like what do you suggest how we should make research an important priority. We are doing something like, see, this quest is one step in that direction, but what are your suggestions to make it even more effective?
Yeah, that's a very important and a very big question to answer. But I think what I personally think is you have, as a clinician, I think you have to think that it will make you a better clinician. You can provide better and more informed care, more evidence-informed care if you do research. So I think if people start thinking that way, that I'm not just doing research to write papers or to become famous, I am doing this so I can be a better clinician. I am well informed about current practices, current evidences. I think that little change in thinking can go long ways. And then, of course, a lot of other things come with resources and a lot of other time. But I think I was trying to give a little bit of examples in that, yes, we have a very well-oiled research system here, but I think some of the simple examples could be replicable in low resource settings with little bit of effort, I think.
Yeah. Over to you, Professor Ashok.
So thank you very much, Harpreet. I think we can keep on discussing, and I just got this idea of having a round table on research, as to how should our priorities be defined and how should we go about it. It can form a very, very interesting discussion, for our country. Our problems are a little different, each one is practicing in a
Yes.
silo, and pooling of data is just not heard of, or let's say it's very, very uncommon for different reasons. We did not go into that. So there are a lot of factors, which actually prevent us from doing world-class research, though I'm sure if we pool our data together, it will be second to none. Probably that data,
Yeah.
because of the huge volume of patients in this country, we will have, very rich data. So anyway, Harpreet, we need to end this webinar. Thank you very much for being here. And I'm sure you opened a different vista for people, to see and appreciate, what is happening around the world. I'm happy to say that Harpreet will be conducting a basic research course for pediatric orthopedic surgeons and also allied specialists, which includes therapists and all those involved in or who have a fancy for research. All of us can come together. We're planning this on the 15th of March in Mumbai. More details will follow, but this will be a whole day program focused on research, the technicalities of research. So thank you very much, Harpreet. I think we have to say good night here. Goodbye to you.
Thank you.
Yeah.
Okay,
Thank you.
bye.
Thank you. Bye. Bye.
Bye, Harpreet.